think by common consensus, the last class was a great learning experience for all of us. Radesh made everything very simple and very precise and very understandable. So we have requested him to continue with that and go for other aspects of MR scan that is useful for surgeons. So Radesh, the floor is yours, or the computer is yours.
Oh, thanks, Ravi. Sir, good evening, sir. So it's really nice to have sir with us today. So what I will be doing is maybe over the next 1 hour, today let us look at MRCP. So this is such a common topic, and also surgeons in their day-to-day practice always deal with gallbladder, common bile duct, common hepatic duct, pancreatic duct. And let us see all this on imaging. Again, I'll just share the screen. Yeah. Is the screen visible now?
Yeah, yeah, good.
Or should I move this somewhere?
No, it is visible. It is
Everything is
everything.
visible. It's very
Everything
nice.
is visible.
Yeah.
So let's start off with the again the photograph of MR. As I told you last time, this is the gantry of the MR. You see this hole here, that is where the patient is moved in. And a small recap for 3-4 minutes for those who were not there in the last class. Once the patient is put into the magnet, there are hydrogen protons in the body which align along the magnet. This is the long axis of the magnet. So just alignment will not give us an image. So what we do is we bombard those hydrogen protons which are in the body with radio frequency pulses. Once radio frequency pulses hit the protons absorb energy. And we all know the energy cannot remain or it cannot be destroyed. So what happens is this energy gets dissipated to the adjacent protons. So when this happens, the signal is caught by an antenna and that is converted to a grayscale image. So this is what happens. Let it be a routine MR imaging, let it be MRCP, let it be MR angiography. So all the physics remains the same. Now, today let's look at MRCP. What is MRCP? MRCP stands for MR cholangiopancreatography. We just don't look at the intrahepatic biliary radicals, common hepatic duct, common bile duct, and the cystic duct, but we also look at the pancreatic duct, its side branches, and so on. So basically, it's a non-invasive technique, meaning we do not inject any contrast when we do MRCP or MR cholangiopancreatography. This is a T2 weighted sequence. So now, if you remember in the previous class, I told you whatever looks bright is a T2, the fluid. If it looks bright, it is a T2 weighted sequence. Now, what is the difference between a T2 weighted sequence and MRCP? MRCP is a heavily T2 weighted sequence. Now, what did we tell you? In a T2 weighted sequence, we wait for a long time and capture the signal over a longer period. And in MRCP, it is even longer. So instead of capturing the signal at say 90 milliseconds, we may do it around 120, 130 milliseconds. So what happens? The fluid starts looking more white. That is what we want. So the bile, which is there, and also the pancreatic secretions, they start looking bright whenever they are in the duct. So now, what physics do we use here? The physics we use here is we suppress the entire background. You will not see anything else apart from the ducts, apart from the CSF which is there surrounding the cord, apart from MR urography, like the urine which is there within the pelvic calyceal system also looks bright. So any fluid starts looking bright. Gastric secretions start looking bright. So that is the sequence we use for MRCP. We don't inject any contrast. There is no radiation. There is no pre-medication or anesthesia which is used in these cases. So on the MR, as I told you, it demonstrates the common bile duct, the common pancreatic duct, and the take-home message here is the MRCP sequence can visualize the PD or the CBD even proximal to the obstruction. Suppose there is a cholangiocarcinoma, there is a clad skin at the hilum, it can easily see the intrahepatic biliary radicals because they are dilated and they are filled with bile. But it becomes difficult when you do an ERCP because you may not go beyond the obstruction if the obstruction is complete. The second take home message here is the MRCP is the basically like a luminogram. When you do a cath lab, when you go to the cath lab and you do a angio, you just see the coronary arteries, but you don't see the wall of the coronary artery. You don't see what is happening surrounding the coronary artery. Similarly, in MRCP, you just see the duct. But what we do is we also do other sequences. I'll show it to you. So these sequences pick up the wall of the CBD, the wall, the pancreatic duct better, the pancreatic parenchyma is beautifully seen. You see lymph nodes, you see vascular invasions, and you also see the ducts being infiltrated by the tumor, which you will not see only on MRCP. So please remember, I always say MRCP is just an icing on the cake, but the actual cake is the sequences what we do. A T1 weighted, T2 weighted, a pre-contrast and a post-contrast study or MR angiography, which shows you the vessels, whether the tumor is infiltrating the vessels, is it infiltrating the portal vein, or are there nodes? Is the tumor enhancing? So all these you can see on other sequences. Now, certain again take home messages here are whenever we do an MRCP, okay, you might have seen you sometimes the radiologist reporting as calculi which are present within the CBD. As I told you in the previous class, whenever there is air does not contain hydrogen protons, so you cannot see air. It is like a calculus. Calculus may contain bile or it pigmented calculus or it may contain calcium, but it may not contain enough number of protons for it to be seen. So a calculus can look black, air can look black, or surgical clips, because again, they don't contain hydrogen protons, they can look black. So we should be extremely careful in such cases. And suppose we put it as a calculus and you open up, you don't see any calculus. So what do we do? What is the next best imaging modality for you to see air? It is CT. So in all cases of MRCP, apart from doing lot of other sequences than the MRCP, we also do a few CT sections so that there is no confusion between air and calculus. Now, when it comes to the visualization of the ampulla, ERCP is any day better than MRCP. You can beautifully see the ampullary region with the scope, and you can easily cannulate and then get a wonderful ERCP picture. So MRCP, if they ask you about the limitation in the exam, You can always say the limitation is air, surgical clips, because they don't contain hydrogen protons, you can't see them. You cannot differentiate a pneumobilia from a calculus in so many cases. So you do a CT. Second thing is for the visualization of the ampulla, it is ERCP and not MRCP. And the next biggest advantage of ERCP is you can do a therapeutic procedure, which you cannot do with MRCP. So you can go ahead, you can biopsy, you can do a stenting. It could be CBD stenting, it could be a pancreatic duct stenting. It can easily be done on the ERCP, but MRCP is just a diagnostic modality. Now, when you send a patient, please again, I repeat, if you want to interrupt, you're free to interrupt. Okay, please, you don't hold the questions till the end. Let us have a good interactive session. And suppose you haven't understood, please ask me not once, twice. You can ask me 100 times. So what are the MRCP techniques? Now, what do we do? Now, should the patient be fasting? Okay. Overnight fasting is ideal because the GB is nicely distended, but 4 hours fasting is enough. No, don't stop any medication what the patient is taking. Let him continue to take his medications. In case he is on insulin also, don't stop insulin. Please give insulin to the patient. Second, it is a heavily T2 weighted sequence. So now, sir, everyone are masters, sir. The moment you say it is T2, they will tell you that the fluid is bright. Isn't it?
Yeah.
Good. So it's a heavily T2 weighted sequence. Then flowing blood again is black. The whole background is black. We will see all this on the images. Now, there are two types of MRCP techniques what we use. We use a 2D sequence and we use a 3D sequence. Now, what is the difference between 2D and 3D? In the simplest terms, if you take a loaf of bread, the entire slab is a 2D sequence. Okay, you are acquiring the whole, say the duct, the liver, the pancreas in one go. It is faster and it's around 4 to 6 seconds of breath hold. But a 3D sequence is like cutting the loaf of bread into pieces. This is a thin section, 0.8 mm, 1 mm sections, which you take and then you add all these images to produce a complete image. You can add 3, you can add 20, you can add 50 slices. So the biggest advantage of a 3D sequence is you can also see individual slices before you fuse them. And last but not the least, and the most important thing is we also do different sequences. It could be a T2, what we call as the haste, or a wipe, which is a T1 weighted sequence. Plus, in cases of tumor or in cases of infection, we also use contrast and diffusion weighted sequence. Now, in the last class, you all have seen what diffusion weighted sequence is. Whenever there is increased cellularity, it will look white on that sequence. That is a diffusion weighted sequence. Now, let's look at a few examples here. MRCP can beautifully show you the... Yes, sir, no issues at all.
Yeah, please continue. Yeah.
Okay, what you stop being the host. I think Dr. Lakshman will be the host.
Yeah.
Yeah, he's joined.
Sanya, okay.
No, he's there. Lakshman sir is there.
Yeah. And I am the host now, so
Yeah.
please go ahead.
Yeah.
Sanya, let her just log in as Sanya. Yeah, okay.
Fine.
Sir,
So,
I think, Sanya was has logged in through your account, which is why probably this is happening.
But it never happened before. It's
Yeah,
happening for
yeah,
the first time. Anyway,
yeah.
please go ahead, Radhesh. Yeah.
Yes. So this is a 3D sequence, and I was telling you it becomes very difficult to differentiate a 2D from a MIPD 3D. What is MIP? Maximum intensity projection. So we take all the sections of maximum intensity projections which we have acquired, and then we fuse them together, which is called as the MIPD image. And one more advantage of a 3D is, in fact, you can rotate a 3D image in the plane you want to. So two advantages of 3D. One, you have thinner sections, so the anatomy is better and also the pathology can be seen better. And the second thing is you can rotate the images in the plane you want. So here you see an aberrant insertion of the segment 6 duct into the common hepatic duct. This is the right hepatic, this is the left hepatic, this is the common hepatic, and then you have the CBD going down. Now, there are four variants of normal pancreatic duct, what we see on MRCP, similar to ERC. So the first one is the descending pattern of the pancreatic duct. You see the pancreatic duct within the body and then it descends down. It comes inferior, then goes towards the ampulla. This is the CBD. This is the pancreatic duct. Now you see the ampullary region. You don't see it well on MRCP at all. But on ERCP, there is direct visualization of the ampulla. The second one is the sigmoid course of pancreatic duct. It is like an S shape. It's like it curves like an S. That is why you call it the sigmoid pancreatic duct. Third one is vertical. You see this pancreatic duct here within the body, and then it comes down straight parallel to the CBD. So this is the vertical course of the pancreatic duct. And the fourth one is it loops actually. You can see the loop here. There is a loop of the pancreatic duct. So there are four variants. One is the descending. Similar to descending is the vertical course, which is more vertical. Then you have the S shape, the sigmoid. Fourth is the loop of the pancreatic duct. Now, let's look at a few examples. Classical choledochal cyst, isn't it? There's a fusiform dilatation of the extrahepatic duct. It is the common hepatic and the common bile duct, but there is no dilatation of intrahepatic biliary radicals. So it looks like a type 1C. Okay, you have the Todani's classification. I don't know, we follow that. So one important thing here is it does not suffice for us to say this is choledochal cyst. Okay, even clinically, you would have suspected a choledochal cyst. But there are certain important things we need to communicate. One, is there an anomalous union of the common bile duct with the pancreatic duct? In this case, there is an anomalous union. You see, this is the common bile duct, which is dilated. This is the pancreatic duct, and the common channel is long. It is more than 1.5 or 15 millimeters in length before it goes and opens into the ampulla. The second thing we need to tell is, are there calculi within it? Is there a growth within the common bile duct or the fusiform dilatation within the choledochal cyst? So in this case, this was just an anomalous union. You see the choledochal cyst and a common long channel. There were no calculi in this case. Now let's look
Radesh,
at,
is it Radesh? Just a clarification.
yeah,
Is it
Ravi.
one of the things that they usually attribute the choledochal cyst is a long common channel anyway? So
Correct.
is that not? Is it not a common feature in every
No, no, no.
Choledocholysis?
It's only, I think, around 15 to 20% of the cases we see this though.
Okay.
We don't see it. But if we see a choledochal cyst, we have to look at the length of the common channel
Common channel.
if it is there. If it is there.
Yeah.
Rajesh, the four types of pancreatic duct configurations that you described, does it have any clinical significance?
No, sir. No, sir.
It's
This is
just an
just a normal
anatomical
way. Yes.
definition. What it is. Okay.
Now, let's look at calculus disease. So it could be cholelithiasis or it could be choledocholithiasis. So now, let's look at the anatomy. You see the right hepatic duct very well, the left hepatic duct, common hepatic duct, then the CBD. You see the pancreatic duct here, which is very thin. Then the fluid containing structures, the the duodenum and the proximal jejunal loops are seen. But now, this is the gallbladder. Now, if you look at the gallbladder, the white area is the bile, and then the dark area is the calculus. So this is an MRCP image. Now it becomes very difficult sometimes to say that this structure is the gallbladder on this plane because you're not seeing the cystic duct, you're not seeing the cystic duct joining the common hepatic duct. Okay. But when you look at the raw data images, as I told you, you look at the T2 weighted sequence, you see such a thick wall of the gallbladder. It's a very, very thick wall of the gallbladder. Then you see the dark area within it. So, which is the calculus. Now, again, you may ask me, suppose there is a choledochoduodenal fistula, and if the air has entered the gallbladder, could this be air? It still could be air. So we have to do CT if there is a doubt to rule out the presence of calculus or the presence of air. Now this is again a 3D MRCP image. And in this 3D MRCP image, you don't see the calculus at all. Here it's a thin MIP, so you see thin maximum intensity projection, meaning we have fused, say, around 10 slices or 15 slices. Though we acquire 50 or 60, we have fused less number. But when you fuse everything, you see the additional fluid coming here, and then you don't see the calculus at all. So whenever you start seeing the MRCP images, suppose you don't see a filling defect, it does not mean there is no calculus. So always look at the raw data like the radiologists, especially the young surgeons. Do not look at the images which look so beautiful and as if you're seeing it when you open up. Okay, there is so much hidden inside. The same thing for you when you open up, you will see the gallbladder, but inside we would have said there is something. You will come out and say, no, this was not there, but we found a polyp or a tumor inside. So it's only when you dissect out, you start seeing, similarly in MRCP, you start seeing smaller, thinner images, you will pick up the lesions better. Now let's look at an example here again. This is a case of cholelithiasis. And this patient also had a pseudocyst here. This is a pseudocyst, not the stomach. And this is the gallbladder and the calculus within. Now, I am very confident and I can tell I don't need a CT for this. I know that this is a calculus. So how do we say it is a calculus? Because it is lying in the dependent position. The patient is supine and this calculus gravitates below into the dependent position. Suppose you saw this black area above, non-dependent area, so you know it can be calculus or it can also be air. So the dependency is usually by the calculus, while the non-dependent area is for the air. And here you see this is a T2 weighted sequence. You see the pancreas here. You see a thin white line inside, which is the pancreatic duct. And this is the pseudocyst of pancreas. So here in this patient, there is no pancreatitis as of now. I can show you one more. This is a coronal or a sagittal image. You can see the calculus within the common bile duct so well. So this is the gallbladder calculus and this is the CBD calculus. There is dilatation of the CBD proximal to the calculus, but the distal CBD is normal. So this dark area here is a choledocholitis and this is not an MRCP image. This is an MRCP image. This is not an MRCP image. So on the non-MRCP images, you can pick up most of the lesions, 99% of the lesions. Just to give a roadmap, MRCP is beautiful. But if you look at the source images, you can pick up everything. So again, this is a patient with calculus chronic cholelithiasis. You can see the calculus here. And these are not MRCP images again. These are all T2 weighted sequences. This is the axial plane. This is the coronal calculi within the gallbladder. This is the one. And this is the pancreatic duct. Next. This was a post-op case. There was a small stump left behind. It was more than a cystic duct. Okay, you see a nice big stump here, but you don't see the calculus at all. You see the cystic duct coming down, joining the common hepatic duct, and this is a small stump of the gallbladder, and you don't see the calculus. But when you look at the T2 weighted sequences, you can look at the calculus so well. This is the stump, this is the bile within it, and you can look at this. This is the calculus. So again, I repeat, please look at raw data. This is just an icing on the cake. This gives the entire diagnosis for you. You can look at the CBD, you can look at the surrounding area, you can look at the pancreas, you can look at the liver, nodal anatomy, everything. Now, for choledocholitis, again, MRCP is the investigation of choice. Because ultrasound, it may be difficult for us because of the adjacent bowel gas to look at the CBD, but for MR, it really doesn't matter. But the take-home message here is on ultrasound or CT, if you have diagnosed choledocholitis, I don't think you need to do an MR at all. Because again, you can look at the pancreas, you can look at the surrounding structures on the CT, and you can also pick up the, if you have picked up the CBD calculus, you need not do MR in such cases. One more example here. This is a case of choledochal cyst. This is the gallbladder. Gallbladder also looks hyperintense. You see the gallbladder overlapping on the cyst here, and when we start rotating, it opens up. Now, you can't see because it's so hugely grossly dilated, you cannot see where is the cystic duct, where is it opening, where is the gallbladder, and what has happened to the common hepatic duct. Now, if you look at the source images, you can in fact see the gallbladder beautifully here. And you can also see there is cystic duct opening here. This is a different plane where you can see the cystic duct opening and then the hugely dilated common hepatic and common bile ducts. Again, this is a 3D. This is a volume rendered technique. It gives you like a 3D image with a surface. We shade it differently and it gives you as if it is very natural, real, as if you have opened. So, but again, it does not tell you what is happening inside. This is just a small software technique, or we call it as volume rendered image. This is a 3D image. This is a volume rendered image. Now, let's look at this, for example, here for a minute. The first image, please look at this image. And then also look at the last image here. Now, if you look at this last image, don't read this at all. Choledochal cyst with CBD calculus. Don't read this. If you just look at this image, you see the gallbladder, you see the cystic duct, you see the fusiform dilatation of the common hepatic and the common bile duct. Plus, you see some dark area here. You don't know what it is because the rest of it is also dark. So you cannot pick up a calculus very well on MRCP. If you do a T2 weighted sequence, you look at this. This is the same case where you see the dilated duct and there is a dark area, really dark area within the common bile duct. So you know it is a calculus. Now, you may ask me, why is it not a tumor? It still could be a cholangio within a choledochal cyst. So in such cases of high suspicion, we do a T1 weighted sequence and we also inject contrast in such cases. Now, if the contrast is taken up by the lesion, we know it's a tumor. If the contrast does not opacify the lesion or there is no enhancement of the lesion, we know we are dealing with a calculus.
Radesh, the because this girl is only 6 years old, the chances
Yeah,
of it being a tumor is very remote.
correct. Absolutely. But again, what I feel, this case is straightforward. You see the meniscus sign.
Yeah,
I'll just show you one more case where it looks like a calculus, but slightly older, as you rightly said. But only thing is, in case of doubt, we have to give contrast.
yeah,
So that is
yeah,
basically the take home message.
yeah.
And the contrast, what we use here in MR, what is it?
Gadolinium.
So it's gadolinium. It is not iodinated contrast, as I told you in the last class. Now, again, the choledocholithiasis, look at this, so beautifully seen here. You see the calculus, you see the calculus here, you see what is this? This is the vertebral body. Looks like a calculus anterior to the vertebral body. No signal within it. Aorta,
Mm.
isn't it? Flowing blood is always dark. I told you in the last class, even if it is T1, T2, only on a gradient echo sequence, the vessels start looking bright. So this is a T2 sequence. This is the aorta, and look at the signal of the calculus. It is almost the same as that of the aorta. Now, aorta looks dark because of the flowing blood. Calculus looks dark because it does not have hydrogen protons. So the paucity of hydrogen protons also makes a structure look black. So this is a patient with choledocholithiasis where you see the calculus beautifully within the common bile duct. Now, this is an MR CP sequence. What do you see? You don't see the calculus at all. You see the dilated duct. You see the calculus here. Okay, maybe, we don't know. But if you look at a T2 sequence, you see the meniscus so well here, and there is a dark structure, you know you're dealing with a calculus. So again, I'm not trying to tell you don't get an MRCP done. I'm just telling you, you have to talk to the radiologist and tell him, I want a T1 weighted sequence, I want a T2 weighted sequence, and eventually you will anyway give MRCP. You give MRCP, but I need all these sequences because I've seen instances where they just do an MRCP and send it. Okay, don't go by that. It will not give you any information. So you have to have T1, you have to have T2 weighted, plus you have to have the MRCP sequence. Now, let's look at, this is a case of, this is your ERCP. Okay, you also see calculi here, which are just the filling defects. And this is the MR, where you see strictures here. The right hepatic duct is narrow, then you see the dilatation. This is the left hepatic duct, which is dilated. Then you see the narrowing. This is the segment 6 duct. You see filling defects within it, which are calculi. So the MRCP here beautifully shows, because it's a quite dilated system, it can show the filling defects very well. And this is a thin MIP, not a thick MIP. If it was a thick MIP image, probably these calculi would have got masked. So you see stricture, you see calculi, intrahepatic ductal calculi. This was a case of cholangitis with intrahepatic ductal calculi. Now you see so much of atrophy here. The right duct, the right lobe of liver is completely atrophied, which you again see in cases of cholangitis. You see the dilated ducts within the right lobe of liver, which is shrunken. You also see calculi within the gallbladder. You also see ducts, the calculi within the hepatic ducts. So this is basically a recurrent cholangitis with atrophy of the right lobe, and you see multiple calculi within the common bile duct. Again, this is an MRCP image. You may see probably one calculi here, which is the largest, but there are multiple calculi within the common bile duct. This is a T2 weighted sequence. This is again a T2 weighted. Why is it T2 weighted? Look at the CSF surrounding the cord. It is bright. So the fluid being bright, it is a T2 weighted sequence. Even MRCP is a heavily T2 weighted sequence, and it will suppress everything, including the liver, except fluid containing structures. Now, let's look at malignancy here. I'll just go, okay. Now, if I just give you this image, don't even look at flat skin. Just look at this image. Now you know there is dilatation of the right duct, left duct. The confluence of the hilum is not seen. You see the common bile duct, which is normal in caliber, and also the pancreatic duct. Now, is it tumor? Suppose we just do MRC. Now, is it tumor? Is it calculus? We don't know. So, but when you go to these images, this is a T1 weighted sequence because the CSF is dark. This is a T2 weighted because the CSF is bright. Now, if you see this, you see the tumor so well. This entire thing is a hilar malignancy, which is a Klatskin tumor. And then you see the tumor here, which is going into the right duct. This is again very, very important, not just the confluence. Now you see the involvement of the right duct, you also see involvement of the left duct, you don't see the confluence at all. Plus, you all can also look at the adjacent structures. Is there lymph node? Yes, there is. You see multiple nodes here. This is the inferior vena cava, the portal vein. This is the aorta, left lobe of liver, and there you see multiple lymph nodes, which you will never ever see on this image. Again, I'm just putting the especially emphasis on the T2 weighted and the T1 weighted, which is so important even before you see the MRCP images. This itself will give you the diagnosis. You see the hilar malignancy, you see the infiltration of the right and the left ducts, you see multiple lymph nodes, and then you can, just for the completion's sake, you can look at this image.
Radesh, does the MRCP give you also infiltration of the liver parenchyma with
No.
this?
On this image, no. On just an MRCP image, no. But when you look at this, you can easily pick up which segment of the liver is involved. So how much of resection is needed, you can easily plan. So that is why it's so important for us to do the T1 and T2 weighted sequences, not just MRCP. Even you can do away with MRCP, I'm telling you, but you can never do away with these source images, the T1 and T2, not even the source, T1 and T2 weighted sequences. Because it is not just showing the ducts. As Ravi said, it's so important for us to also define the infiltration, which segment is involved. Is 4A involved? Is 4B involved? Or is segment 5 involved? So it becomes important for the operating surgeon.
Radesh, I presume when we ask for an MRCP as a clinician, you
Yes,
would
sir.
automatically do the T1 and T2 sequences as well.
Yes, sir. We do it, but
Yeah.
only thing is you also need to check, sir.
Yeah.
Sometimes what happens is they just do the MRCP and they give this 3D images like this, and we go by what we see here. We
Mm.
just say that yeah, these ducts are infiltrated, but the liver can be infiltrated, sir,
Yeah.
and nodes.
Yeah.
Now, this example I'll show you. So nice. So you just look at this image here for a minute. Don't look at the other images. The right hand at the bottom, the last image here, you see dilated CBD. This is an MRCP image. Okay, don't look at the rest. So on this MRCP image, you see dilated CBD. Then you see a beautiful meniscus. So whenever we see meniscus, we are taught it is calculus. Okay, so now we know this patient has a calculus, distal CBD, proximal there is an upstream dilatation, IHBR dilatation is there. But when you go back and see the images on T1 and T2, just look at the difference here. This is aorta. Now you know this is T2 weighted sequence, vertebral body. This is the aorta, right crus, left crus of diaphragm. But this is the CBD tumor. Look at the signal difference between the tumor and aorta. This looks gray, flowing blood looks black. And let's go back for a second and look at a calculus again. Look at this. The calculus looks black, almost like aorta. So if you see a less black area within the common bile duct with a dilatation, the first thing we think of is tumor. So Ravi, this is what I was telling you.
Yeah,
So now we see, look at this, it tells you it is a calculus.
calculus.
But now we see the tumor. Now the tumor posteriorly, we don't know whether it is involving the wall of the CBD. So in such cases, we give contrast. It is not just the tumor. We also look at the adjacent wall. We look at pancreatic infiltration, and we also look at lymph nodes. And this is a coronal T2 weighted sequence where you see the tumor so well. It is not white. This is a gradient sequence. That is why inferior vena cava and aorta are white, and CBD is also white. And you see the tumor, which is gray. This is a T2 sequence. Flowing blood is black. This is a gradient sequence. Flowing blood is white. Now, when it comes to portal biliopathy, you can always look at the collaterals very well. You can look at the collaterals. Now, if you just look at this MRCP, again, we go back to that. If you look at this MRCP image, you know there is a stricture. Yes, there is a stricture. There is a dilatation. Then you see the CBD here with the gallbladder overlapping in this plane. But when you look at the source images, you will see there's multiple dark structures. This is a T2 weighted sequence. That is why you see the flowing blood as dark, and they're going all around the CBD. And also there is some duct. You see the blood vessels going here along the right hepatic duct. You see the filling defect here, or as if it is cut off. So these are all blood vessels. They are not strictures. They are not tumor infiltrations. So this is a classical case of portal biliopathy. You see multiple collaterals. You see splenomegaly, and you also see the collaterals here. So this is a case of portal biliopathy. Again, the source images have told you the diagnosis. It is not the MRCP alone. Now, when it comes to bile duct injuries again, MR is beautiful because there invariably when there is a transaction of the CBD to visualize the proximal portion of the ducts. It could be intrahepatic biliary radicals or the common hepatic duct, or where exactly is the trauma. MR can beautifully pick it up, because in this case, you see the common hepatic duct and there is an abrupt cutoff. You don't see the CBD also, but sometimes you can see a thin CBD going down, but in this case, there is complete obstruction. And on all these images, we can clearly tell you where the obstruction is, what is the size, because when you plan a hepaticojejunostomy, you always wait for the dilatation, and MR can clearly tell you what is the diameter of the common hepatic duct. Or if you want to anastomose to the right or the left duct, we can give you the measurement of the right or the left duct. Now here, one again take home message here is, it could either be a transaction of the CBD, or sometimes maybe the surgical clip would have gone across the CBD if it's a very, very bad gallbladder, and these things do can happen. So in such cases, we also correlate these with CT, because CT can pick up the metal very well, and we don't get any artifacts. We know where the metal is, and we know that this is the clip may be causing the obstruction to the CBD or the CHD. Now, if we just do an MRCP, now this is the same patient. Now, when we do an MRCP, now this could be a Gladstone. Fine, though the history is there, but suppose the history is not there, then you will start thinking, oh, this is a hilar malignancy. But actually, this patient, and in fact, if you carefully see, you don't see the CHD at all, but on the source images, you see the confluence. So this is very, very important. Here, because of this clip which is there, you're not seeing the CHD better on this MIPD image. But when you look at the raw data, though the clip is there, you can still see the anastomose, the hilum here, right duct, left duct, and the common hepatic duct here. So the injury is below the level of the common hepatic duct. Now, there's one more example here. This is again post-cholecystectomy, and then you see a lot of fluid, subhepatic fluid here, the perihepatic fluid. And now if we carefully see the raw data images, let's go to MRCP first. Oh, sorry. Okay. So this is a thin MIP where there is a track which is going there. I don't have a 3D of this because it was very difficult for us even to see this track here. So when you do a thin MIP, or when you look at the raw images here or the T2 weighted, you see there is continuity of the cystic duct with the fluid there. So we know there's a leak of the cystic duct, which is responsible for the perihepatic fluid or the bile to go out. So it can be clearly seen on this raw data or the T2 weighted images. Pancreas divisum. So how do we identify pancreas divisum? If you look at the main pancreatic duct, when we do an MRCP, we look at the main pancreatic duct, and this main pancreatic duct, see, this is the main pancreatic duct here, which is going anterior to the common bile duct. So if you see the the pancreatic duct going anterior to the common bile duct, this is the common bile duct, this is the region of the ampulla, and you see the pancreatic duct anterior to the common bile duct. So now we know we are dealing with pancreas divisum. So that is the cause of pancreatitis and a pancreatic pseudocyst. So we can pick all this so well on the T2 weighted images. And this is again a T2 weighted with a thin MIP. You can see the pancreatic duct going anterior to the common bile duct. Now, this is an MRCP image. Now, if you are given just this, you don't know whether this is stomach or is it a collection. We don't know. And then there is something going like this. Now I know this is pancreatic duct because I am biased, because I've already seen these images. So I know it is pancreatic duct. But just on the MRCP images, becomes very difficult for us to say this could be any fluid containing structure, not just the pancreatic duct. So it's important for us to look at again, I emphasize on the T2 weighted images. Now, let's look at chronic pancreatitis. Remember DISC, disc. There are four things what you need to look at on the MRCP image or also the ERCP image. First is a ductal dilatation, irregularity of the duct, foci of stenosis of the duct. You can have a string of bead appearance. And last but not the least, calculi, DISC. Now, if you look at this image, you see dilated pancreatic duct so beautifully seen on this. You see the CBD, which is normal. Then you also see a pseudocyst and in the region of the tail. This is again a T2 weighted where you see the dilated duct so well. That is one. The next thing is this is the dilated duct and few side branches are dilated here. You look at the small side branches, they are beautifully seen on this T2 weighted sequence because the resolution is so good. We do a 1.52 millimeter sections, so you can pick up the irregularity of the duct very well and also the side branches. So there's a dilated pancreatic duct with dilated side branches. So we are dealing with chronic pancreatitis. Now, the third thing is the duct irregularity again. It is not a smooth duct. The outlines are definitely irregular. You see ductal dilatation, ductal irregularity. You see multiple calculi. You see this? This is the dilated pancreatic duct. You see multiple filling defects within the pancreatic duct. Is it clear? So these are the multiple calculi and the signal intensity will be similar to the flowing blood. Again, multiple ductal calculi, this chronic pancreatitis, we can skip this. Now, if we look at this, this is an MRCP image. You see the gallbladder, you see the CBD, plus you see the dilated duct, but you're not seeing the side branches so well. It looks like a tumor because most of the PDs, when they dilate, when there is a pancreatic head carcinoma, this is how we see with the smooth outline. So until we look at the T2 weighted image, it becomes difficult. So these are large calculi, the intraductal calculi. And when we do cases of pancreatitis nowadays, we also do a CT and give HU values, the Hounsfield values like we give for the renal calculi. Because at least I've heard through my gastroenterology colleagues that they can also do a lithotripsy. Sir, is this followed, sir? Some people do lithotripsy.
Very much so. Very much so. It is. Yeah.
Now again, this is again one more case of chronic pancreatitis. You look at the side branches so beautifully seen here. Multiple dilated side branches. Because this, again, just a dilated duct and one side branch dilatation can also give us a clue that this is chronic pancreatitis. This is the MRCP image. You see the dilated duct and you see these side branches here, but not as good as these. Now, malignant bile duct obstruction, like there could be carcinoma ahead of the pancreas, which can give rise to dilated ducts. So you see the dilatation here. You see the large mass which is there in the pancreatic head. You see the large mass within the pancreatic head, and you see a smooth dilatation of the pancreatic duct. This is a double duct sign. Okay, you can get it in periampullary carcinomas, and you can also get it in head of the pancreas carcinomas. So unlike the smooth dilatation, what you see in carcinomas, you see irregular dilatation in case of chronic pancreatitis. So that is how you differentiate. Okay, for the want of time, Like we can't talk about the inflammatory pancreatic head lesions because you can differentiate a carcinoma head of the pancreas from an inflammatory pancreatic mass, IPMs, because IPMs allow the pancreatic duct to pass through them, unlike carcinoma head of the pancreas, which infiltrate the duct and give rise to dilatation. So this is pancreatic head carcinoma. So once if we just look at this, it becomes very difficult for us. It looks like a calculus, very classical meniscus. So this is a case of calculus within the terminal CVD, choledocholithiasis with dilatation. Actually, if you see the source images, then you know you're dealing with carcinoma head of the pancreas. Pancreaticopleural fistulas can also be picked up very well with the source images or even the MRCP, where this patient had a ductal injury and this was tracking into the left pleural cavity. So this is the pancreatic duct, and you see the leak in the perisplenic area and also extending into the pleural cavity. So a high amylase lipase level within the pleural fluid, you ask for an MRCP, invariably we can demonstrate where the site of the leak is. Is it the tail, which is a common site, or is it going up from the body into the mediastinum and then opening into the pleural cavity? You see this? The entire duct is leaking here and going into the pleural cavity. So this is an MRCP image. It becomes very difficult for us even to identify the duct. I just brought this up not to discourage you from asking, but please look at MRCP images in the end. First look at T1 and T2 weighted and then the MRCP images. Now, pancreatic duct injuries also can be beautifully picked up. This was a patient who had pancreatic ascites. The ascitic fluid showed elevated levels of amylase and lipase. So if you see this, this is the pancreatic duct. You see, this is where the disruption is, and this is where it is leaking. So you can pick up the site of the leak very well. And is there a disruption of the duct? So it is definitely better than CT when you look at pancreatic duct injuries. This is again a T2 weighted sequence. You see the disruption here, but not as well as you see it on the T2 weight. Again, you see the disruption of the duct leaking into the peritoneal cavity. So the last two slides, just to conclude, what are the tips for MRCP? Whenever you look at the images, let it be a T1 or a T2 weighted image, the moment you see a black area or a hypointensity within the CBD, it is not a calculus always. It could be air or it could be a mass. So do a CT to confirm air. If it is a mass, remember on the T2 weighted sequences, it is not as dark as iota. It is not as dark as a calculus if it is a mass. But if it is a air, it can be as dark as iota. It can be as dark as calculus. So you do a CT to rule out air. You cannot miss air on CT. So in case of chronic pancreatitis or pancreatic carcinomas like hepatomas, it is a one-stop shop. You can do a T1, you can do a T2, you can do a contrast, you can do an MRCP, you can look at the vascular anatomy, you can look at the ductal anatomy, everything you can do in 30 minutes. Now, what is the trick? What we sometimes, to look at the ampulla, we ask the patient to have a little bit of water and then we put him right side down and then we scan so that the water within the duodenal C or the second portion of the duodenum, okay, stands out. If there is an ampullary carcinoma, it will marginate or it will surround the tumor. So this is a small trick what we use. Always combine routine sequences with MRCP. Don't do MRCP in isolation. I think this is the take-home message I want to give, especially for the postgraduates. And sometimes we use a small dose, 5 to 10 ml of iron syrup, like it could be a heme up or some Dex Orange or whatever. Why do we do this? Because iron on T2 weighted images looks black. If there is too much of gastric secretions, too much of secretions within the duodenum, we give this and we just make the patient to turn around 3 or 4 times and the whole thing gets suppressed. So we see only the CBD pancreatic duct beautifully. So these are the things what we follow. So you can always suggest, you can give a small dose of heme up if there is, or iron syrup if there is too much of secretions. So with this, I would like to conclude. Thank you very much. I know it's already late. Okay. So thank you. Any questions? We can always answer.
Yeah, thank you very much, Raja. I think it was a beautiful exposition. You made the subject very simple. Thank you very much for helping us with this. One very simple fundamental question. Because of the intense magnetic field in the whole room, what are the precautions you take before you even enter the room?
Oh yeah. So this, in fact, the last class I brought it up. So certain things.
This,
Now,
yeah, but you mentioned about the internal, the MR compatibility of internal, prosthesis and things like this. But
yes, sir.
I would like you to dilate on the external things that we
The
precautions that
one,
we take, please.
yeah. So the most important thing what we have to follow is it is not just the patient who goes in, but also the attenders who accompany the patient. One, don't have any ferromagnetic substance in your pocket. So though we do the screening, sometimes patients just keep a small coin inside. Okay, they don't tell us they are carrying a coin with them. And believe you me, this can rock, it can go at such tremendous speed, it can injure the person who is inside. So don't take any ferromagnetic, don't take coins. Now, gold, silver is okay, platinum is fine. But what happens is these things can get heated up. Okay, so please don't try to wear even a gold ring. Try to take it out for your own safety, or else there could be small superficial burns. And the third thing is, especially some dresses have metal things within them. Okay, like say a jerry.
Chikan work and things like that.
Yes.
Metal things
So
on it.
these
Yeah.
can be very dangerous. This can be very dangerous. And because of the RF, there can be a fire which can start inside. Okay, so please avoid even that metal. Next, don't carry keys. Don't carry your credit cards. Don't take your watches inside because of the very high magnetic field. As I said, all this can get damaged. In fact, I have made the same mistake. Okay, I have gone in with my purse, my credit card stopped working. Okay, because they can destroy the magnetic strip or even the chip which is there. So don't take them. So this is what you wear. And also try as far as possible, have a cotton clothing. If you don't have, please ask, or we also provide all those when we take the patient inside. Next, the inside ones. Now, cardiac pacemakers. Okay, please tell if you have a cardiac pacemaker or if your patient has a cardiac pacemaker, ask them before you send them for MR or MR, any MR for that matter. It is not just MRCP, brain, spine, or even joints, whatever. That is one. Next, neurostimulators, cochlear implants. These are all absolute contraindications. The patient may not have a cochlear implant, but the attender who goes along with the patient sometimes can have a cochlear implant. So it's important for us not just to look at the safety of the patient, but also their attendees. That is one. Next, the commonly asked question. Now, there is a shoulder. there is a hip replacement, shoulder replacement, knee replacement. Are they contraindications for MRCP? No, they are not contraindications. Intramedullary nail is not a contraindication. Cardiac valves, current day valves, are not a contraindication. You can
Mentioned that
take
last
these
time.
patients. Okay, valves are not. Stents are absolutely not a contraindication. You can go ahead and do an MR 1 hour after stenting. There is absolutely no problem. So the main contraindications are cardiac pacemakers, neurostimulators, cochlear implants.
The newer pacemakers are MR compatible, right?
Yes, sir.
The
So we, in fact, we have done a study on the pacemakers, cardiac MR compatible pacemakers. And these pacemakers have absolutely no problems. You can take these patients in, but you need to find out if these patients have an MR compatible pacemaker.
Second question. I know there are some newer machines which are not so problematic as the older machines about the sound that the magnet makes. I would like to know, why does it make a sound? And I know that you give them certain things to cover the ears and reduce the sound. What is the present state?
So the current day machines, there is a significant reduction in the decibel levels. Now, because the gradient coils keep vibrating inside the magnet, they are the ones which produce the noise. And we have mufflers inside now, the magnet, which can reduce the sound level significantly. But still, there is noise, there is sound. We also have what is known as silent scans. But only problem for us is the resolution is not as good as the regular scan. Maybe there is a 20-30% drop in the resolution. So that is why we do not advocate a silent scan until and unless it's a child and we need to see something gross, then it's fine.
To counter the problem with claustrophobia in a kind of a tunnel-like MR, you have a concept of open MRs now. What is the current state of that?
So if you look at the current day, sir, I think the open MRs have really become obsolete. No one uses an open MR. The reason is, I always say there are there are two schools of thought: Tesla easy people and Tesla crazy people. So the higher the Tesla, okay, the more crazy it is in terms of magnetic strength, the better is the resolution. So to achieve this resolution, you always have a tunnel. In an
Okay.
open system, the resolution is almost 50% less than the closed systems. So open MRs now almost it is gone, sir.
So
Now
how do you address these people who are claustrophobic?
so we usually put their feet in, sir. Until and unless we are doing a brain scan or a cervical spine or a brachial plexus, we usually, so for MRCP especially or for abdomen, we put their feet first. And that way they feel less claustrophobic.
Any other question? Ravi, for your closing remarks, please.
yeah. Again, I think this was it is honestly telling. I was also one of these people who Radesh referred to as people who just look at the MRCP, the picture, rather than looking at the T1 and T2 sequences. This was the greatest learning point for me. I think a lot of extremely good examples, and emphasis on significant points which we need to remember. I think it was really very informative for me. Certainly, I think it is probably for all of us. Thank you, Radesh.
Thanks, Ravi.
Thank you and good
Thank
night.
you, sir.
Yeah.
Good
Thank
night.
you all.
Good
Have a
night.
good night.